Good afternoon, everybody. We're excited to have you join us for this Hypertension Education Series webinar. The Hypertension Education Editors, in conjunction with the American Heart Association Council on Hypertension Skill Committee, present this Centennial webinar that focuses on hypertension treatment trials, past, present, and future. We would like to thank Trudy Mayer, the managing editor of the journal Hypertension, for championing this initiative. Dr. Matt Luther of Vanderbilt and I, Stella Daskalopoulou from McGill University in Canada, will moderate this session, which will last for about 45 minutes, followed by 15 minutes of questions and answer. So please place your questions into the chat. For this important session, we are fortunate to have today three distinguished speakers and world-renowned researchers in hypertension. First, Dr. Raymond Townsend from the University of Pennsylvania, who will talk about the past. Dr. Ernesto Schiffrin, professor from McGill University, who will present to us about the present. And finally, Dr. Naomi Fisher from Mass General Brigham and Women, who will talk to us about the future. We would very much like to thank our speakers for their time and participation. Now I will hand the electronic podium over to Dr. Townsend, who will talk about past landmark studies. Thank you.
Thank you, Stella. And I hope you all can see my first slide here. Just quick call out, in the upper left corner is Paul Dudley White. Next to him is Lewis A. Connor, who have named things in the AHA for their legacy. But these six people you see at the top were the instigators in 1924 for the formation of the American Heart Association. These are my disclosures. In the interest of time, I'm not going to read them one by one. I will tell you, though, that I plan in the next 19 minutes or so to cover three types of clinical trials that have been done in hypertension prior to the introduction of the data from the SPRINT trial that my colleague Ernesto will cover with you shortly. And those have to do with surgical approaches, the dietary approach, popular at Duke, and then finally I'll talk most of the time about the antihypertensive medication trials that have been part and parcel of what we do today. So contrary to what you may have expected, I think surgery leading off here is important because at the time that clinical trials in hypertension started to make their ways into journals, there wasn't a lot of medication usage, but there was a bit of these thoracoabdominal lumbar thoracic sympathectomies popularized by Reginald Smithwick, shown at the upper right-hand corner of your screen, and published in JAMA, and really well written. And I won't tell you that this was a great way to lower your blood pressure because they don't really talk much about the blood pressure reducing effects, although people that had the surgery were fairly advanced, often at the cusp or frankly at the edge of heart failure and other problems associated with hypertension. But the thing that stood out from the early surgical experience was the survival benefit. Looking, for example, at group 3, and there were 4 types of severities here, 3 being the next to worst, but the Group 3 was the biggest change in 5 years of survivorship in those that underwent the so-called Smithwick procedure versus those who decided not to or weren't deemed good operative candidates, who became the control group at the time. So that at least set the stage for it. You could potentially improve mortality with doing something for blood pressure. Batting second is the Duke diet, which began right at the end of the Second World War, popularized by Walter Kempner up on the upper left-hand side there at Duke University. And I'll just show you a snippet from his data. And the graph you see on the left-hand side are the blood pressure levels of someone that was desperate enough to stop eating salt and be part of Walter Kempner's rice diet cohort. And you can see it took about 2 months, but the blood pressures, after you reduced your sodium intake to somewhere between 5 and 10 milliequivalents per 24 hours, that meant distilled water and other things in order to totally eliminate sodium from your diet. And you can see what happened to the body weight, particularly in this poor soul that had cardiac failure, no doubt some edema, but the nice drop in weight and a nice drop in blood pressure, but at the result of eating a diet that is just really hard to stay on, even faced with mortality otherwise as your alternative. But at least it set the stage for the role of sodium reduction in blood pressure therapy. And I'm going to quickly point out to you that if you look right above the word pre-sprint on this slide, you'll see a thing, 639 results from my PubMed, my brief PubMed search here. So, seat back trays upright and seatbelts buckled, because I'm not covering all 639, but I hope to cover important ones that led to where we were at the time the Sprint trial was published. I start with this one because most people think of the VA cooperative trials as the first time we showed blood pressure reduction by medication does something good. This was published a year before the first VA cooperative data came out in JAMA. It's in the Journal of Chronic Diseases. It was done in Baltimore. And there was 82 people involved in this 17-month-long study. And though randomized, it wasn't double-blind. That wasn't popular back then. And you had to have a diastolic over 100 on 3 occasions in order to get into it. I point this out because what you're seeing here is the result of 17 months worth of open label, basically therapy. You're randomized to the group where they had to treat you. And all the numbers you see on the right-hand side under placebo, under that causes of failure, failure means an endpoint in the trial, largely were located. 19 of the 25 were in the placebo group, 6 of the 25 in the drug group. You can read the fine print here, but at the bottom line here, and this is an early trial, but notice the ethnic disparity here. Black patients made up the majority, overwhelming majority of this early trial, demonstrating that they not only could benefit from high blood pressure, but were willing participants in a clinical trial that was done in Baltimore. We published a few years ago, and this is the only thing I would recommend for homework reading after my time is over, but we looked at the top 10 mark, which we consider the top 10 mark landmark studies. And this is Elizabeth Edwards at the time from University of South Carolina at Columbia, who was our go-getter to put all this data together. This is the table out of it. And I only use this to show that once the 2 VA cooperative trials, the 1967 one and the 1970 one, were finally out there, then JNC, the first report came out, chaired by Marv Moser, courtesy of the High Blood Pressure Education Project. And once HDFP came out, and I'll cover both of these in a second, that's when the second report came out. And then I'll try and link the JNCs as we go along here with the clinical trials. The man in the upper left here is Ed Fries from the VA system. They enrolled patients with diastolics of 90 to 129 in the hospital and the 4th to 6th day of hospitalization purely for the purposes of working up their blood pressure, not because they had a particular reason to be in the hospital. But they were randomized into the 2 groups you see, treated with drugs, and it's thiazide and reserpine with hydralazine added as second line, versus a placebo, a matching placebo. And this is 2 years of follow-up for the highest levels of diastolic, those of 115 through 129. And what they found in the next slide here is that there were a total of most of the events, 27 of the 29, occurred in the placebo group. You did not need a PhD in biostatistics to see the relevance or the significance of such a disproportionate occurrence of morbidity in the group that was treated at 115 to 129. It really laid the groundwork for, yes, in the absence of malignant hypertension, it's worth reducing essential or primary hypertension in the interest of saving target organs and saving lives. And that led to the first, the next one was the 90 to 114. The 105 to 114 was a win. The 90 to 105 was not. Could not show the benefit there. That left the question about what do we do with these 90 to 105 type blood pressures? And the answer was partially provided by the HDFP, the Hypertension Detection and Follow-Up Program. Now, HDFP was much larger. You're looking at 10,000 people here instead of a couple hundred. And I'm only showing you the top line results here, and the issue here is death, all-cause death. And what they found is that when you used stepped care, so people randomized to the stepped care approach to treating their blood pressure, start with one drug, add in a stepwise fashion, compared to the referred care back to the community, let them have the usual care given to hypertensive patients circa 1978 to 1980. What they found for the 90 to 104 type of diastolic blood pressure range, and back in this era, it was all about the diastolic. You can see here in the solid line, which is the group for referred care, there was more death then compared to the stepped care arm, which is in the dashed line, whether it's systolic or diastolic blood pressure, it produced a benefit in mortality when treating the 90 to 104. That helped produce the second JNC report, which listed what they meant by stepped care. And it was starting with a diuretic, adding these antiadrenergic agents, going to a vasodilator, and then deep breath going to ismalin, guanethidine, which was, everybody's bane at the time. And it was part of the reason there were clinical pharmacologists back in this era, because these drugs were pretty challenging to use. In the fourth iteration of JNC, they made a nice graphic here. So all I show that is to improve the quality of the steps involved in the stepped care process. So now we've got demonstration that lowering diastolic blood pressure, even in patients, and some of the HDFP patients had target organ damage and diabetes, which was novel to put in a clinical trial at the time. That led to okay, let's get our highest risk group and let's really hammer on the cardiovascular risk factors. And let's go after men, because at the time, the thinking was men had a disproportionate amount of heart disease compared to women. Consequently, the MRFI trial, this multiple risk factor intervention trial, often called Mr. Fit, was undertaken in the bottom right-hand side here with the comment by George Lundberg, who was the editor of JAMA from 1982 when this was published to 1999, 17-year stint or so at JAMA. What he said here, and this is the take-home point, this was huge. I mean, this wasn't just a smallish trial. This was a fairly large trial, over 12,000 people involved here, 28 institutions, 250 investigators, and a lot of patients screened for this. They had to smoke, they had to have cholesterol, and they had to have blood pressure, which was put in a Framingham risk calculator. If you popped out being at 15% risk or worse, then you were in the trial. And then they worked on, either intervention or just back to usual care at your doc to reduce cigarette usage by dietary approaches, reduce your cholesterol, and treat with stepped care your blood pressure. And here's the bottom line shown on the lower left. After years of follow-up, 7 years actually, it's a long time, there was no discernible difference because the control group here, this is not a double-blind placebo-controlled type of thing. This is differences in care approach, not in particular medication taking patterns. They did not show a benefit in death. There were 260 deaths in each group at the end of the time period. So it was sort of we can do it because the blood pressures were lower, the cholesterols were better, and the cigarette usage was reduced, more so in our special intervention compared to our usual care group, but it didn't demonstrate the survival benefit that was expected. And so it was sort of okay, park the car for a minute, and let's think this a bit further. In the meantime, one of the things that happened in the background is that the FDA approved captopril hydrochlorothiazide, a compound med called Capizide at the time, in October of 1984, and shortly thereafter approved hydrochlorothiazide with bisoprolol, a combination pill called Xiac at the time, and eventually made them first-line therapy. Prior to that, there was no indication for a combination product as first-line therapy. And shortly after the FDA did this, and it started to get around that this is a better way to lower blood pressure more effectively, particularly when you're starting with at least 20 millimeters or so of blood pressure to reduce, the International Society for Hypertension in Blacks was the first one to espouse the use of a fixed dose combination approach in managing blood pressure. And they did this before the JNC got on board with it as well. And I'll point that out again, because here we are in March of 2003. When you get to JNC7, you'll see that it's later in the year. And just to point out here, right in the sort of right-hand side, middle spot there, initiate combination therapy when you need more than 20 millimeters of mercury. Moving ahead, everything's been about the diastolic up till now, until blue color on the lower left there, and Bob McDonald, both from the University of Pittsburgh, prominent in the field of epidemiology at the time, introduced the SHEP, S-H-E-P, systolic hypertension in the elderly program. The main point here was the association between systolic pressure and stroke, shown by Framingham and others. And the question was, could you lower blood pressure? Could you do it safely in elderly people? And could you do it safely in elderly people whose diastolic blood pressure is less than 90, consequently, they wouldn't have necessarily qualified for treatment because in this era, God forbid I admit this, but 100 plus year age was considered an optimal systolic blood pressure. I'll just show you one picture from this study, and that is the stroke reduction. The stroke in the dashed line is in the placebo group. This was placebo-controlled, randomized, and the stroke rate in the solid line was those treated with the active drugs, the chlorthalidone and atenolol, with other bailouts should they still need med on top of that, 4.5 years long. But it really set the stage for the focus on systolic blood pressure, which eventually was taken up in the next iterations of the JNC. I put the treatment of mild hypertension study up next, something many people do not know. It's called TOMS for short. Part of the reason I shamelessly did that is because I was part of the TOMS study. There were 4 centers. I ran the Pittsburgh one with respect to recruiting and randomizing patients in this. Look at the spate of drugs at the bottom of the screen here. The goal here was to treat mild essential hypertension with a monotherapy and lifestyle measures together, not individually, but now together. And when you look at the approach here, monotherapy plus lifestyle, you're looking at the basis for the all-HAT study, which the TOMS study was the predicate for. So all-HAT was based on our experience in TOMS. You see the blood pressure reductions here, both 12 millimeters of diastolic and 16 millimeters of systolic with monotherapy, and getting people to walk a mile a day, eat less salt, and lose a little bit of weight. Those were the goals in TOMS. I put this up because here's that issue with combination drug therapy. 6 months later, JNC got on board with it as well. Moving on from TOMS to the big one here, the major outcomes in high-risk hypertension patients in the all-HAT study. So all-HAT was a blockbuster. It looked at 4 different monotherapies built on the TOMS study, and it randomized 44,000 people or so into the 4 groups. The diuretic group is bigger than the other 3 groups for a lot of reasons that had to do with study design, not worth going into right now. But here are 4 candidate drugs that you might have gotten as part of the all-HAT study. 42,000, sorry, not 44,000. The popular calcium channel blocker, the very heavy-duty diuretic, the alpha blocker, and the ACE inhibitor. And so at the end of the day, we didn't get to the end of the day because partway through this study, they found that patients randomized to the alpha-1 blocker arm, taken off their diuretic in order to participate in the study, and then randomized to a drug known to, in retrospect, kind of potentiate sodium retention. The doxazosin arm had more either putative or actual heart failure associated with it. And in the year 2000, at the ASN meeting in Toronto, actually, Janice Douglas got up in front of everyone and said, in the all-HAT study, they have pulled the doxazosin arms, kind of the thud heard around the world. There was about an 11% occurrence of endpoints in all-HAT with the diuretic, with the ACE inhibitor, and with the calcium channel blocker. Couldn't tell the players apart, even with the color coding there. You can't find the individual lines. So in this particular study, the take on it was that the diuretic, chlorthalidone, is unsurpassed in terms of its ability to reduce endpoints in a population of largely essential hypertensive patients. And a lot of the people managing all-HAT also became authors and people behind the JNC7 report, which espoused strongly the importance of systolic blood pressure based on SHEP. It also gave us this thing here, which FDA has been fond of using to say, what is a clinically relevant reduction in blood pressure? And the answer is at least 2, but better at 4, and ideal at 5 millimeters of diastolic blood pressure or systolic blood pressure. In this case, it's systolic. But it gave, if you wonder where the FDA got the idea that 4 or 5 millimeters of systolic is important, it comes from what was published and presented in JNC7. The idea of compelling drug indications came from JNC7, and again, combination drug therapy was espoused here. And I'm going to finish out the litany here with some rapid fire, so this will really be quick. The UK PDS studies, by the time I was, first came to Penn in the early 90s, there were 20 some of them already published. But the one that I liked is this one. which is the UK PDS 38, which demonstrated that when it comes to a diabetic, treating their blood pressure is actually more beneficial than treating their glucose. At least at the time, we didn't have all the SGLT2s and GLP-1 RAs, et cetera, that we have now. But the blood pressure control really made more of a difference than the glucose control. So put the blood pressure in a diabetic really on the map for sure. The accomplished trial, headed by Ken Jamerson at Ann Arbor, was another very large study, demonstrated the best blood pressure control to date and compared two combination products, an ACE inhibitor and a diuretic, and an ACE inhibitor and a calcium channel blocker. It turns out the ACE inhibitor, calcium channel blocker, was a little better, particularly in the lean subjects. So it kind of made us think twice about that stronghold that diuretic therapy had on the first steps in terms of managing high blood pressure. And I'll finish out here with a call out for the African American study of kidney disease and hypertension. When you look at this, it's always abbreviated ASK. They drop the H all the time, but technically it was both a high blood pressure, 2 levels of blood pressure in ASK, as well as a kidney function study over time. And the ASK study gave us a couple of things to think about. The first was it was all Black Americans in the ASK trial, and it showed that an ACE inhibitor could be useful in slowing the progression of kidney disease, and it was tolerated well by Blacks. What it failed to show for kidney disease outcomes is that a more aggressive compared to a less aggressive blood pressure treatment goal really made a big difference in terms of CKD progression. So that kind of, we're up to close to 2014 when Sprint, and at least 2015, 14, around that time period when Sprint came out. So I'm done. You can now take a deep breath. That's my email at the bottom. If you don't hear what you're interested in knowing further today, welcome to send me a note, and thank you very much.
Thank you very much, Dr. Townsend. As always, amazing presentation. So, so after this excellent presentation of the past landmark trials up to Sprint, we will hear from Dr. Ernesto Schiffrin, who will present us from Sprint through current FDA-approved drugs. Thank you, Dr. Schiffrin.
Thank you, Stella. Can you see my slides well?
Yes,
So
yes.
I'm going to be speaking about the Sprint trial and current and newly approved agents for treatment of hypertension. And the rationale for the Sprint trial comes from this study, the Prospective Studies Collaboration published in 2002, that shows clearly that systolic blood pressure is correlated with cardiovascular events, in this particular slide, stroke mortality, but also coronary artery disease mortality, in rises. The stroke mortality or the coronary artery disease mortality rises monotonically as blood pressure rises, starting at 115 millimeters of mercury systolic, and similarly and increasingly for increasing age, and the same both for male and female. So this provided the rationale for intensive blood pressure lowering, which is what the Sprint trial attempted to accomplish. And so for the Sprint trial, 14,692 patients were assessed, and I won't go through the details, but essentially 4,680 patients were included. These were all high-risk individuals above age 50 who had a systolic blood pressure at entry of at least 130/80, and who were treated, who were randomized into an intensive therapy group and a standard therapy group. And here you can see the systolic blood pressure during follow-up throughout the 3.26 years of treatment, with standard therapy achieving a mean blood pressure of about 136 millimeters of mercury, and the intensive arm of the Sprint trial achieving 121 millimeters of mercury. Over here, you can see the number of medications that were used in each of the arms of the study, of about 2 meds for the standard therapy arm and 3 antihypertensives for the intensive therapy. And down here, at the bottom, you can see the number of patients who achieved the 3.26 years of treatment. This is the primary outcome. The cumulative hazard for the primary outcome was, let me move this out of the way, was reduced by 25%, relative risk reduction, highly significant. As you can see here, all myocardial infarction was not significantly affected, neither was non-MI acute coronary syndrome. However, all heart failure was reduced, had a relative risk reduction of 38%, and cardiovascular death, a relative risk reduction of a whopping 43%. All stroke, a little shockingly, was not significantly affected. Importantly, during the trial median follow-up, the number needed to treat to prevent a primary outcome was 61 individuals. Here you can see the forest plot of the primary outcome according to different subgroups. And you can see that most groups benefited. They're all to the left of the identity line. Previous or not chronic kidney disease, older or younger than 75 years, male or female, black or non-black, previous cardiovascular disease or not, and increasing blood pressures, systolic blood pressures at entry, all benefited from intensive treatment being better than standard treatment. There were serious adverse effects in a small number of patients, importantly, more in the intensive therapy than in the standard treatment group. And I won't go into details, but you can see here that hypotension, syncope, electrolyte abnormality, including hyponatremia or hypokalemia, and as well acute kidney injury or acute renal failure occurred in a small percentage of individuals, significantly more for hypotension, syncope, electrolyte abnormality, and acute renal failure in the intensive therapy group. So the conclusion of the SPRINT trial was that it was necessary to treat 61 patients at the lowest systolic target of less than 120 millimeters of mercury versus 140 to prevent one additional primary outcome, and to treat 90 patients to prevent one additional death over a period of 3.26 years. Important additional results from SPRINT included the publication in JAMA of 2016 showing that elderly subjects more than 75 years of age benefited as much as younger subjects from intensive treatment, with significantly lower rates of fatal and not fatal major cardiovascular events and death from any cause. SPRINT Mind, which demonstrated reduction of incident minimal cognitive impairment, but not probable dementia by intensive treatment, published in 2019. And finally, a follow-up, which demonstrated importantly that beneficial effect of intensive treatment on cardiovascular and all-cause mortality did not persist after the trial. There was no legacy effect. Given increasing outpatient systolic blood pressures in participants randomized to intensive treatment following the trial, these results highlight the importance of consistent long-term management of hypertension, published in JAMA Cardiology in 2022. So let me pass on to the currently approved agents for treatment of hypertension. This is a busy table from my colleague Sandra Taylor, who's an associate editor of the journal I'm editor-in-chief of, the American Journal of Hypertension, published a few years ago in the New England Journal of Medicine. And you can see the main agents used as initial choices for antihypertensive therapy. And I don't want you to concentrate on all the details, except that here you have thiazide-type diuretics, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers of both the dihydropyridine type and the non-dihydropyridine type. Importantly, among thiazide-like diuretics, you have hydrochlorothiazide. indapamide and chlorthalidone, and the latter two, chlorthalidone and indapamide, are longer acting and more powerful. And why is this important? Because, as Ray mentioned, we like to use single pill combinations. Why? Because studies have shown that most patients require at least 2 agents. And in order to improve adherence and reduce pill burden, it has been demonstrated in a number of trials that use of single pill combinations increases adherence and improves outcomes in hypertensive patients. Unfortunately, it is hydrochlorothiazide that is combined with either ACE inhibitors or angiotensin receptor blockers rather than any of the longer agents, except for indapamide combined with perindopril and chlorthalidone combined with azilsartan. So combination therapy is ideal even in stage 1 hypertension, and it requires the use of combinations of either angiotensin receptor blockers or ACE inhibitors with thiazide-type diuretics. You should never combine ACE inhibitors with angiotensin receptor blockers, since this has been demonstrated to result in an increased incidence of acute kidney injury and hyperkalemia. There are also single pill combinations of angiotensin receptor blockers and dihydropyridine calcium channel blockers. In the next slide, I simply remind you the 4 classes of agents used as initial choices. But again, I remind you that single pill combinations of either angiotensin receptor blockers or angiotensin converting enzyme inhibitors with a thiazide or thiazide-type diuretic, or a calcium channel blocker combined with an angiotensin receptor blocker, can be used as initial therapy, even in stage 1 hypertension. Now, 15 to 20% of patients that we treat with hypertension do not respond with lowering of blood pressure to maximally tolerated doses of 3 antihypertensive agents, including a diuretic. These are patients that we classify as resistant hypertensives, and in these subjects, we need to add additional medication. And the first agent to be added to the 3 classes of initial therapy for hypertension are the mineralocorticoid receptor blockers. Following the Pathway 2 trial, spironolactone has been demonstrated to be effective in reducing blood pressure. It is well known that spironolactone may have anti-androgenic effects, and these are absent in a more selective mineralocorticoid receptor antagonist such as eplerenone, which can be used preferentially in males, although it is less potent than spironolactone and needs to be used in twice daily doses. Additional approved agents to consider include beta blockers, central alpha agonists such as clonidine, hydralazine, which is usually used for temporary blood pressure control, or minoxidil, which is used preferentially in chronic kidney disease. Since it produces hair growth, it is well tolerated by males, but may be less tolerated by females. Now, my next area that I've been asked to talk about is the area of the newly approved agents to treat hypertension, and that includes the dual endothelin ETA-ETB receptor antagonist aprocitentan. So this shows the endothelin vascular system with ETA and ETB receptors on smooth muscle cells that are acted upon by endothelin produced by the endothelial cells. Endothelin also acts in a paracrine fashion on ETB receptors on endothelial cells. This shows how aprocitentan blocks ETA and ETB receptors on smooth muscle cells. It also blocks the ETB receptors on endothelial cells. These ETB receptors are actually clearance receptors, which results in raising plasma endothelin, which is a signature of a dual ETA-ETB receptor antagonist. Now, ETB receptors in endothelial cells stimulate nitric oxide and prostacyclin secretion, which produce vasodilation. However, this does not impair the potency of aprocitentan, the dual ETA-ETB receptor antagonist, to lower blood pressure. It is also a well-tolerated agent that was demonstrated in the precision study to reduce blood pressure in resistant hypertension. Without going into too much detail, patients for this study were recruited based on the presence of resistant hypertension and absence of secondary hypertension. They were put on a standardized background therapy for 4 weeks, including valsartan, hydrochlorothiazide, and amlodipine. They were then subjected to a run-in placebo for 4 weeks and then randomized double-blindly for 4 weeks into aprocitentan 12.5 milligrams, 25 milligrams, or placebo. Following that, they were exposed for 32 weeks to aprocitentan 25 milligrams, always throughout this period under the standard background therapy of valsartan, hydrochlorothiazide, and amlodipine. The FDA required a withdrawal phase, a double-blind withdrawal phase of 12 weeks, where the patients were re-randomized back to either placebo or aprocitentan 25 milligrams, followed by a safety follow-up period of 30 days. Here you see the blood pressure in the response to administration of aprocitentan. We have the initial placebo double-blind period with a huge placebo effect, as you can see here. The difference between placebo and 12.5 milligrams, as 25 milligrams as well. Then the randomization to, or the transfer of all the patients to aprocitentan 25 milligrams during this part 2 single-blind period. Finally, the re-randomization back to placebo, where the blood pressure goes up, as you notice, exactly to where the level that placebo brought down the blood pressure, indicating probably that this was the level of blood pressure of these patients at the beginning, and the remaining controlled blood pressure in the subjects that remained on 25 milligrams of aprocitentan. This shows the ambulatory blood pressure, 24-hour systolic ambulatory blood pressure, placebo, and 12.5 or 25 milligrams of aprocitentan during the double-blind period. And as the patients go through the double-blind withdrawal, blood pressure rises with placebo. And over here, the blood pressure levels, you can see here that under placebo, the blood pressure goes back up, whereas it remains controlled under aprocitentan during daytime and nighttime. Importantly, the subgroup analysis shows that patients who most responded to treatment included subjects over age 75. As well, patients with the highest degree or highest amount of urinary albumin creatinine ratio at baseline are the ones who responded best. And finally, those with eGFR below 60 mils per minute per 173 square meter surface are the ones as well who responded best over here, indicating that this treatment may be particularly favorable in individuals with chronic kidney disease. Since aprocitentan does not produce hyperkalemia, this may represent an advantage over the addition of a mineralocorticoid receptor blocker, which in subjects with an eGFR below 40 may induce easily elevations of potassium that may limit the use of the mineralocorticoid receptor blocker. There were adverse events, and they were mostly edema or fluid retention. rarely hospitalization for heart failure because of the fluid retention. However, the edema or fluid retention could be controlled by up-titrating the diuretic. So in summary, in high-risk patients with resistant hypertension, and this was a high risk group of patients with a 30% presence of diabetics, 30% chronic kidney disease, aprocitentan resulted in a statistically and clinically relevant office and ambulatory blood pressure lowering, particularly the latter during the night. Aprocitentan was associated with restoration of normal dipping in a substantial portion of patients, which may be important for outcome. Proteinuria was significantly reduced with aprocitentan. Fluid retention developed but could be controlled by up-titrating the diuretic. However, based on data from animal reproductive toxicity studies with other endothelin receptor antagonists, aprocitentan can cause birth defects and fetal death when administered to a pregnant patient and therefore is contraindicated during pregnancy. So in summary and conclusion, aprocitentan has been approved by the FDA to be used at a dose of 12.5 milligrams daily in adults with difficult to control hypertension in addition to other antihypertensive medications. It comes with a boxed warning for embryo-fetal toxicity because it can cause birth defects. It must not be taken during pregnancy, and acceptable forms of contraception should be used before initiating treatment, during treatment, and for 1 month after stopping treatment, and pregnancy must be excluded before treatment initiation. Aprocitentan is only available through certified pharmacies that participate in the approved REMS or Risk Evaluation and Mitigation Strategies program. And with this, I finish my presentation. Thank you very much.
Thank you so much for this wonderful presentation, Dr. Schiffrin. And last but not least, Dr. Naomi Fisher will talk to us about the future devices and current phase 2 or 3 trials. Thank you so much, Dr. Fisher.
Thank you. I'm really honored to join my wonderful colleagues on this Centennial. To look into the future, I needed perspective. You've already heard from Dr. Townsend. The first hypertension treatments consisted of drastic lifestyle changes and a surgical procedure, which was in fact the ancestor of modern catheter-based renal innervation. From mid-century through the early 1990s, there's an explosion of pharmacologic therapy and the development, and you can see when the drugs hit the scene. But the last approved new class, renin inhibition, was back in 2007. Then a 16-year hiatus without any new drugs. 2024, you just heard, saw approval of a novel drug. And of course, now we are celebrating the 1-year anniversary of approval of renal innervation. We've watched many classes of new drugs appear on the horizon over the past decades. Some have failed, some have stalled, some appear to be succeeding. Dr. Schiffrin already elegantly reviewed aprocitentan, approved for resistant hypertension in May. So I'll discuss the 3 drugs classes below it and conclude with renal innervation. First, a perspective on the non-steroidal MR antagonists, because they made a big splash. And since we'll be sitting in that corner of the renin-angiotensin system, it makes most sense to bring in aldosterone synthase inhibitors next. Let's focus on what these 2 classes have in common, which is suppressing aldosterone. Aldosterone has declared itself a worthy foe. We have long understood its classic roles, reabsorption of sodium and volume retention. We now recognize its harmful tissue effects, resulting from MR, mineralocorticoid receptors, that block both the classic and tissue functions of aldosterone. The MR receptor, the mineralocorticoid receptor, is expressed in multiple organs and especially throughout the kidney. So since 1960, we've had only 2 steroidal MR antagonists, and now multiple non-steroidal cousins have appeared. They are highly selective for the MR, and they were developed in part with hopes of fewer side effects, like less hyperkalemia. But as it's turned out, these new drugs, and you see some of them listed here, they've shown more modest reductions in blood pressure compared to robust falls with the steroid-based MR antagonists. Only one, isaxarenone, is approved for hypertension, and that's in Japan in 2019. One, finerenone, is approved by the FDA to slow renal decline and for cardiovascular protection in diabetic kidney disease. These drugs may prove better for cardiovascular and renal protection than hypertension, so let's move on to more promising treatments for blood pressure. The aldosterone synthase inhibitors. For over a decade, biochemists have been struggling to create a selective inhibitor of aldosterone synthase that doesn't also lower cholesterol. And the major hurdle is related to a very high degree of amino acid sequence identity, a 93% homology between aldosterone synthase, CYP11B2, and cortisol synthase, 11-beta hydroxylase, that synthesizes the production of cortisol. And now we're there. The new ASIs, aldosynthase inhibitors, are highly selective for CYP11B2, resulting in less formation of aldosterone and less stimulation of the mineralocorticoid receptor without touching the production of cortisol in the zona fasciculata. And advocates of aldosynthase inhibitors state that this approach really treats the primary problem for much of hypertension, which is a dysfunctional increase in aldosterone. Baxdrostat is a long-acting, highly selective aldosterone synthase inhibitor. In bright hypertension, patients with resistant hypertension on 3 drugs were randomized to placebo or 3 different doses of baxdrostat. The background medications were continued, and you can see there were dose-dependent decreases in office blood pressure, with the 2 milligram dose substantially reducing blood pressure, 20 millimeters of mercury, and placebo-adjusted 11 millimeters of mercury. As anticipated, baxdrostat lowered urinary aldosterone in a dose-dependent fashion and also serum aldosterone. It caused an anticipated rise in renin and no change in cortisol. Next came the HALO, another phase 2 trial in patients with uncontrolled hypertension where baxdrostat was added to 1 or 2 meds. The HALO study was null. The blood pressure fell substantially, 16 to 20 points on baxdrostat, but the negative result was largely driven by blood pressure falling to an unexpected degree in the placebo group. We await results that will hopefully be cleaner from the ongoing phase 3 trial, BaxHTN, which is testing baxdrostat in over 700 patients with uncontrolled hypertension. That study is currently enrolling, and results are expected in late 2025. Lorundrostat is another aldosynthase inhibitor with positive phase 2 trial results. It lowered blood pressure significantly in the Target HTN trial compared to placebo, with an additional lowering of plasma aldosterone by about 70%. Here you see the difference in systolic blood pressure being between placebo and treatment, 9.6 and 7.8. The initial cohort were patients who had suppressed renin, but then it needed to be expanded to complete the study. Interestingly, blood pressure reduction was similar in both those with suppressed and unsuppressed renin. Also, blood pressure fell much more in those patients who had obesity, consistent with prior hypotheses. And in addition, in those patients taking background thiazide diuretic therapy. Many of us are on the edge of our seats now, awaiting the results of ongoing trials with aldosynthase inhibitors, including 2 pivotal trials with lorundrostat. Enrollment for both is complete as of this fall, so results may be known in the first half of 2025, including from the Launch HTN phase 3 trial in patients with resistant hypertension on 3 to 5 medications. So to wrap up where we stand with aldosynthase inhibitors, these drugs have been studied mostly in hypertension, and we're awaiting results of phase 3 trials in hypertension. Of course, not yet stated, but obviously they may be exquisitely suited for a large subset of hypertension patients who have primary aldosteronism. There was a small study with dexfadrostat published this year. 35 patients with primary aldo, the drug lowered blood pressure and lowered the aldo-renin ratio. Those were their outcomes. This new class of drugs have had favorable safety profiles with no cases of cortisol insufficiency and a low incidence of mostly mild hyperkalemia and hyponatremia. I think how different their effects and their side effects will be compared to the MR antagonists, both in primary hypertension and in primary aldosteronism, remains to be seen. And now we turn to a whole new way to think about therapy for hypertension: injections. Once considered futuristic, injectables have become mainstream for conditions like diabetes and obesity. RNA interference technology is now targeted against liver-derived angiotensinogen, the unique source of all the angiotensin peptides. You may have heard about two RNA-based mechanisms to target liver-derived angiotensinogen: the direct antisense oligonucleotide and a small interfering RNA. The final result of both of the mechanisms is the same. Translation of the angiotensinogen protein is inhibited. There was one antisense agent reported early success in lowering angiotensinogen, but there are no active trials, no active reports of ongoing trials. So let's focus now on the small interfering RNA, zilebesiran. Zilebesiran is proceeding through active clinical trials. In KARDIA-1, testing different doses as monotherapy, blood pressure fell significantly. Angiotensinogen levels were reduced by more than 90% at 6 months with 300 or 600 milligrams. Above, you can see here the changes from baseline in blood pressure. And because there was a rise in placebo, those are not counted here. This is falls in baseline blood pressure. And the least squared mean differences compared to placebo are listed here. So the take-home message was that a single subcutaneous dose significantly lowered ambulatory blood pressure for up to 6 months. It really suggested the potential use of quarterly or perhaps biannual dosing of this drug. I'd like to take a moment here to thank Dr. Bakris for all he did as a scientist and as a human being. We miss you, George. Data from KARDIA-2 were presented as an ACC late breaker earlier this year in 672 patients. One dose, single dose of 600 milligrams of zilebesiran, lowered the blood pressure as an add-on therapy against placebo in patients who had mild to moderate hypertension. And you can see the falls in blood pressure compared in patients who were taking the diuretic indapamide was the greatest fall. Also, substantial fall with amlodipine on board, and less so with an ARB olmesartan. The blood pressure fall was sustained to 6 months in the first two groups. We have to talk about safety. With this agent, non-serious adverse effects were mostly mild, including injection site reactions and mild hyperkalemia, some hypotension, and eGFR decline. But again, most were transient and resolved. So the safety profile is encouraging, but we must await more data. There are also concerns, I should mention, about the prolonged action of zilebesiran. What about cases where we really need angiotensinogen and they need the cascade to be turned on urgently, like sepsis or hypotension or bleeding? There is a reverse siRNA silencing technology tested so far in SHR, the spontaneous hypertensive rat, which normalized pressure. So now where are we? Enrollment has begun in KARDIA-3, a trial in patients with high cardiovascular risk, including one cohort who has a GFR from 30 to 45 with multiple doses of zilebesiran. And for the final segment, an entirely new pillar of antihypertensive therapy is here. This question is what I used to ask. And here is the 2024 version. Renal denervation is here for good. Renal denervation, of course, is a device-based therapy targeting both the efferent sympathetic and the afferent branches of the nervous system. We all thought renal denervation was dead. After near demise in 2014, there was a resurgence, a result of more rigorous, standardized trial design, enrollment criteria. We have a new generation of positive trials, I'm delighted to report. 2 devices have been studied intensively. The first is the radiofrequency spiral device, which has 4 electrodes delivering ablation to 4 quadrants of the renal artery. Here you're looking down the barrel, and you can see a typical protocol per patient would involve renal arteries and the branch arteries, which about 45 to 50 ablations, lasting about a minute each. The application of ultrasound in the renal vessels represented a newer technology for renal denervation. The Paradise catheter uses ultrasonic heating from a central transducer that's based inside of a balloon filled with water. The cooling water protects the endothelium. Ablations are shorter, as you can see, about 7 seconds each, and they're delivered only to the main renal arteries, not to the branches. So energy is transmitted to a depth of where the renal nerves lie. Renal denervation has been proven effective across a wide range of hypertension severity, from mild to moderate to patients with true resistant hypertension in the Radiance Trio trial. And because I know you want to see the data, here they are, the rigorous randomized trials showing efficacy in the multiple sham control trials. The spiral trials here, these first 4 are the radio frequency, looking at a fall in 24-hour ambulatory blood pressure monitoring. And the Radiance are the ultrasound trials here, and you can see the stars represent clinical significance. The Radiance trials met their primary outcome in all. Such that the FDA approved both devices in November of 2023, with a very broad indication, I think you'll agree, to reduce blood pressure as an adjunctive treatment in patients with hypertension if lifestyle modifications and medications don't work. National and international guidelines and statements are consistent in their bottom line, which I'll share with you now. Renal denervation should be considered for 2 groups of patients who have sustained, i.e. not just white coat, and uncontrolled hypertension. The first group are those patients with true resistant hypertension. I think most of us agree that patients in the second group, larger group, are also good candidates. Renal denervation is appropriate and has the real potential to help many patients who can't take enough medication to control their blood pressure. We all have the firsthand experience that for some people, medications are simply not an option. For a host of reasons, studies have taught us that many patients would actually prefer a procedure to control their blood pressure. So renal denervation has proven safe, with essentially no serious procedural-related side effects and an excellent long-term safety record to date. There are 2 post-approval trials ongoing at multiple centers throughout the US and the world, collecting real-world data with the Paradise ultrasound system and with the spiral system within the Affirm trial. They're non-randomized. Patients are all getting denervated to collect data on safety, efficacy, and durability. So I'm going to conclude here with a look forward, sitting at the Centennial, reviewing novel medications and procedures, and I'm going to choose to conclude my segment on new treatments with this statement. We need transformations beyond new therapies. We almost need them more than we need new therapies. We have dozens of therapies. Many of them are highly effective, they're safe, they're inexpensive, yet we're controlling only 1/4 of our patients with high blood pressure. So we have to focus huge efforts on other elements. Yes, we need new meds and new devices from the biomed and biotech industries. But we also need new tools for blood pressure measurement, digital health management, especially as we shift away from hospitals and clinics and care delivered at home. We're going to learn a lot from big data, enabling broader precision medicine and new treatment targets. Healthcare delivery is going to allow scaled implementation, and it must defy cultural and economic barriers. And finally, we have to engage patients and each other and our colleagues to focus on education, improve adherence, and more fundamentally, prevention. I think through educational efforts like this, we hope our battle against hypertension will be won by the time the AHA's bicentennial rolls around. Thank you.
Thank you very much, Dr. Fisher. I think we don't have time for questions, but I think the presenters did an amazing job, and we want to extend our sincerest thanks for their exceptional informative presentations. In under an hour, they expertly covered the entire history, current landscape, and future of hypertension, provide us with valuable insights into the critical topic. After today's recording is produced, it will be placed on the AHA Professional Education Hub, which is at the education.heart.org. And to access this and all other hypertension education series webinars, please go to the AHA Journal's .org/hype/education. Thank you all for joining, and we hope you enjoyed this Centennial webinar. Have a wonderful evening. Thank you.